Hi, everybody. Good evening, good afternoon, good morning, wherever you are. It's 7 p.m. in Paris, 7 p.m. in Torino, 6 p.m. in London. And it is my great pleasure to welcome you to this new journal club by the International Academy for Clinical Hematology. I'm Mohamad Mohty from the Sorbonne University and Saint Antoine Hospital in Paris. And today, my guests are Professor Graham Jackson from the UK and Professor Francesca Gay from Italy. Before going into the Journal Club, I'd like to acknowledge Adaptive Biotechnology for supporting this IACH Journal Club through an unrestricted educational grant. And the steering committee of the IACH has chosen recently this paper published in the Journal of Clinical Oncology. And this is the paper entitled Minimal Residual Disease After Autologous Stem Cell Transplant for Patients with Myeloma, Prognostic Significance, and the Impact of Lenalidomide Maintenance and Molecular Risk by Dr. Detoot and colleagues. And we are glad having with us Professor Jackson, who is the co-senior co-author of this paper. And the other panelist, as it is always the tradition in the Journal Club, is an expert in this field, but who did not participate or contribute to the paper. So you can see here the summary of this work. I don't think I need to spend a lot of time to convince this audience that evaluation of minimal residual disease and its impact on patient management is really a very, very hot topic in the field of multiple myeloma. And here, the investigators used a large phase 3 trial, namely the Myeloma 11 trial, and Professor Jackson will tell us later, will give us a few more details about this trial. So they examined within this trial the relationship between the MRD status and the outcome of patient post-transplant, especially with respect to the use of Len maintenance. And they were fortunate enough, or I would say they were visionary enough, that they were able to obtain an evaluation at 2 time points, namely at 3 months, but also 9 months. You can see and read the sensitivity, but of course we'll discuss these issues during the Journal Club. And of course, please don't hesitate to send your questions, to post them using the chat box or your comments. And of course, I'll do my best to share them with our panelists. And when we look to the comment of the associate editor who handled this manuscript when submitted to the JCO, Dr. Susan Lynch from New York, actually, you can read what she wrote. MRD negativity post-auto is associated with significantly longer PFS and overall survival, irrespective of the molecular risk status and the use of lenalidomide maintenance therapy. She added that serial MRD measurement might help to identify low-risk patients requiring only a limited period of maintenance. Of course, we will discuss all of these keywords because you can appreciate this lovely statement by Dr. Lynch. Every word, I would say, counts. And here you can see these elegant PFS and overall survival curves from the paper. I think an image is much better than a long speech. You can see the prognostic impact of MRD negativity, the red curves compared to those patients who remained MRD positive, the blue curve. But it's not only about PFS, but it's also about overall survival, which is very interesting because in multiple myeloma, usually it's very complicated to evaluate overall survival and I think find differences. So this was true at 3 months post-auto, but also at 9 months. And the difference is quite impressive. We're talking about a hazard ratio of 0.2, which means like 80% difference in terms of the outcome, which is quite amazing. And looking into overall survival, we're talking about 67% difference in terms of outcome between those patients who are MRD positive versus patient with MRD negativity. So actually, I'll stop here and we'll start now the discussion with Professor Jackson and Professor Gay. And again, the SOP of the Journal Club is about always asking first, and in addition, we have a lady here. And by the way, Dr. Gay, congratulations for your award during the COMI Congress last week. We're very proud of you. But actually, we planned this Journal Club a long time before the award, so there's no bias, guys. Okay, so my first question is to you, Francesca. You did not contribute to this work. You didn't include patient. You are not a co-author, but obviously you've seen it like myself. And what was your first reaction? Did you say, wow, this is amazing, or wow, it's another Me Too article or something like this? What are you feeling? Besides congratulating Graham for this great work and his co-authors, what would you say about this work?
Thank you, Mohamad, and thanks again for the congratulations. So I read deeply the article, and I think there are some data that really are very strong, and this is of course something important in a paper because this is a huge trial with a centralized evaluation both for MRD and for the patient risk in terms of high-risk chromosomal abnormalities. I also think that the data on the impact on MRD on both PFS and also overall survival, which is incredibly important, of course, are very strong and are clearly in line with other data presented in the literature. So this data confirms the impact of MRD negativity on outcome. And to me, it's important because it confirms the impact of lenalidomide maintenance even in MRD negative patients who has a prolonged progression-free and overall survival if they receive maintenance, and also in patients with high risk that, of course, even if MRD negative, they have an outcome that is basically inferior to the standard risk patients, but better than those patients who don't get MRD negative. So to me, it's well known the impact of MRD negativity on outcome, but in particular, it's important to look also at the efficacy of lenalidomide maintenance in these patients and in patients with high risk. And these are, to me, key messages from this paper as well.
Fantastic. It looks to me that you are very positive, which yes. I do share your enthusiasm. So Graham, before going into the details of the article and the different subtle issues, maybe we can remind our audience a little bit about the Myeloma 11 trial, because I guess it's a relatively old trial. I'm not sure everybody attending this meeting, this journal club, is aware, because that would allow to set the stage, I think, for the discussion, the design and the results and the endpoint of this trial, and how did you sneak in this MRD evaluation?
Well, first of all, thank you for inviting me to talk about this paper, and also, again, congratulations to Francesca. So the trial really began back in 2008. So it was a long time in gestation, and it's a large study. There's over 2,500 patients in the transplant eligible arm of the study, which I think gives power to some of the results. It was a study looking at Revlimid and thalidomide based triplets versus a carfilzomib quadruplet. But I'm not going to talk about the induction therapy, but all the patients went on to have a transplant. And then at 6 months, they were randomized to receive either lenalidomide maintenance in standard form, and that was given until disease progression or intolerability, or no maintenance at all. And in the context, again, of the study, this was before the CALGB, the IFM studies, and Phil McCarthy's meta-analysis were published. So we didn't know the impact of Revlimid maintenance. And as you know, we'd previously looked at thalidomide maintenance, which showed some interesting effects, but was very intolerable. So we planned to do an MRD analysis at the time of starting the maintenance randomization. And then we wanted to look at the impact 6 months later into the study. And obviously we have, as Francesca said, centralized MRD assessments and centralized cytogenetic assessments to go with the study. So this paper is really looking about the interactions of 3 factors. It's going to look at the impact of maintenance, the impact of achieving MRD negativity at 2 time points, and also the impact of standard versus high-risk cytogenetics. So you've got 3 competing factors, and we wanted to look at how these 3 competing factors interacted. Because we've got very long follow-up now, we can look at OS as well as progression-free survival in both the 3-month time period and the 9-month time period. I think as we now know, obviously we would have done things differently in the light of current knowledge, but that's what we did when we conceived the trial back in 2008.
No, excellent. And this is why I thought it's important to clarify these issues, because obviously retrospectively or in hindsight, we can always, criticize and say, well, you should have done it this or this. But obviously, the context of the trial in 2008 is, of course, totally different from 2022. And actually, if we go into the details, because I think this is very important for the interpretation of the results. In this trial, you've used as a technique flow cytometry, multicolor flow cytometry, and we're talking about the threshold around 10-4, 10-5. But we know today that with NGS, you can achieve a threshold, an evaluation up to 10-6. So maybe, Francesca, whether you can describe to our audience the differences between the techniques and the importance of having maybe a deep threshold, sort of a more sensitive technique. Although I do appreciate that the International Myeloma Working Group at the moment recommend the 10-5.
Yeah, so we can reach 10⁻⁵ both with flow cytometry or with NGS. The 2 techniques, as you know, have some advantages. I think one of the main advantages of of flow cytometry going up to 10⁻⁵ is that basically you don't need to have a sample from the patients prior to therapy to define this patient that is negative at a certain time point, like maintenance. So it has a great feasibility and can be looked at in all patients. But with NGS, instead, we need to have a sample that is at the time of diagnosis, and sometimes, unfortunately, this sample is not available. The cost can be different. NGS is basically more expensive now than flow. Both techniques can go up to 10⁻⁶, even if to reach the sensitivity of 10⁻⁶ can be more difficult than to 10⁻⁵. You need the adequate number of cells and so on. there is a good concordance between the two techniques, flow cytometry and NGS, or at the cutoff of 10 to minus 6, the next generation flow cytometry that can go up to 10 to minus 6, and NGS. At the same cutoff, they have a good concordance. Of course, there are the advantages that I mentioned. Of course, there are data now showing that getting to 10 to minus 6 gives let's say, a better description of what could be the outcome of the patient, because 10 to minus 6 is not equal to 10 to minus 5, and the PFS and the overall survival of patients getting to 10 to minus 6 is better than to 10 to minus 5.
No, this is really excellent, and I do appreciate, indeed, in 2022, probably NGS is highly sensitive, and one would say, well, if you can take it even to 10 minus 7, it's going to be even better. But clearly, 10 minus 6 is going to be probably the standard of care, or the state of the art at some point. That brings me to the point, Graham, that I think in the study, when I looked into the material method, actually you were able to reach, which is great, by the way, but still, I thought it's a weakness, a sensitivity around 4 times 10 minus 5. But I believe the long-term follow-up of the study allowed you actually to see these differences. Am I correct in my interpretation?
You are correct, and of course there are some interesting things that go on in MRD status. We know that it's a continuous variable, so that 10 to the minus 2 is better than 10 to the minus 1, 10 to the minus 3. And I guess one of the things we have to think about in a large academic study is also deliverability. What percentage of people can you measure down to 10 to the minus 6? So at 10 to the minus 5, we got 92% informative samples. So that's quite impressive. And we certainly got samples down to 10 to the minus 6. One of the things I think you have to do is look at what you can achieve on a regular basis. And we know that if you look at studies that go to 10 to the minus 5 and 10 to the minus 6, the number of people where you have a good measurement at 10 to the minus 6 are much lower. So in defense, I think it's good to measure what you can, and the deeper the measurement, undoubtedly, the better the predictive value. But in large studies, I think 10 to the minus 5 is very feasible. It's deliverable to a large number of patients, and is still, as we see from this study, still quite informative.
Excellent. So let's look into the timing now. And in this analysis, Graham, and maybe Francesca, you can comment on this. You've chosen 3 months and then 9 months. So sort of a 6 months difference. And I guess, although maybe at the time you do, when you have designed it, you didn't think about this concept today that's quite popular of sustained MRD. It was just about measuring this. What do you think, Francesca, about these 2 time points? Do you believe these are the right time points, or maybe we should have, I don't know, used 4 months or 6 months and then 1 year later? How are we going? Assuming tomorrow we start doing MRD routinely, when in that setting of auto transplant, we may wish, if we have time, to discuss outside transplant, but in transplant, what are, I'd say, the key timings you would consider for MRD measurements?
I think the plus 3 months after transplant is standard. I mean, it's the evaluation pre-maintenance that you can consider in most patients, because you need to wait a certain time to see the disappearance, for instance, of the M component, and we know that can be present for months, even after transplant, even when the bone marrow is negative. So I think you need to wait at least a couple of months, and the 3 months is also the time point that we commonly use when we check MRD.
But can I interrupt you? We have a comment from the audience saying, maybe why don't we allow a couple of months more for the consolidation? Because many centers do consolidation. And obviously at 3 months, you're not yet done, I think, with your 2 cycles of consolidation. Is this a relevant comment?
Well, I think it is if you want a pre-maintenance evaluation. It depends on what is your endpoint. I believe that one of the major role in the future for MRD will be deciding if to modulate treatment during maintenance and maintenance duration. So you need a pre-maintenance time point. Could be 3 months after transplant if you don't do the consolidation, or a bit later if you do the consolidation. 3 months to me is okay if you don't plan a consolidation. Otherwise, it would be nice to have the consolidation and thereafter the MRD evaluation.
Yeah.
During maintenance, I think 6 months is the minimum time that you need of maintenance before testing again the MRD. Regarding the optimal time point, I honestly do not know. You have the definition of sustained MRD by the MWG criteria that is at least 1 year of MRD duration. So it could be reasonable to have maybe 6 months and then another one after 1 year, or just 1 year to see at least for 1 year if the patient is still MRD negative.
So Graham, if you have to do it again today, what would be the time points that you would choose?
Well, clearly consolidation is, as Francesca says, is important. So I think it's the pre-maintenance slot, whenever that is after the transplant, is very important to do. And then I would do 6 months, because what you see from our data is that hazard ratio for PFS and OS improved dramatically if you're still MRD negative at 9 months compared with 3 months. And we also saw a lot more patients who were MRD positive go negative on lenalidomide maintenance than on no maintenance. So that's an important factor. The other thing I think that I would stress is that some of the people who were positive at 3 months went negative at 9 months had the same outcomes, interestingly, as the people who were negative and negative. And the people who were negative and went positive had the same outcomes as the people who were positive and positive. So that's quite an interesting factor. But now I think I would also add in a 12-month time point to see how that dynamic continued. But at least at 6 months, you've got an ability to assess all of the people who are going to become negative more slowly, and you can detect those people who are starting to progress or who are worryingly still MRD positive 6 months into maintenance, because that's the group who have the poorest outcomes and where you need to potentially change your assessment or your intervention.
So talking about the kinetics of achieving MRD negativity, we have a question, and I think this is related to the data we have from the Cassiope trial, which could show that actually achieving early MRD negativity, and in the Cassiope trial, the observation was about after induction, which I don't think you have in this study, and then maintaining or sustaining MRD negativity later on, the outcome would be better than remaining MRD positive early and then becoming MRD negative later. Here, what I can hear is that once you became MRD negative, actually, that's good news. Am I correct in my citation, Graham?
Certainly, we didn't assess MRD pre-transplant after induction like Cassiopeia. So our first assessment was at the start of maintenance. So I can't compare what we showed with Cassiopeia because of different time points. But I think if you come negative within that first 6 months of maintenance from a low level of positivity, you're probably going to do just as well. And the opposite is also true. If you become positive having been negative, then that heralds a poorer outlook.
Okay, excellent. So here, the question for you, Francesca, and we have actually a couple of questions about this. We're talking mainly about the prognostic impact of MRD. And this prognostic impact of measuring MRD is now clearly well established. The data are very robust and they are consistent actually across many trials from different countries, different cooperative groups. But the question is, and I'm asking this because one of the focus of this paper is about looking into the impact of len maintenance and molecular risk. And you are leading currently a trial, the Perseus trial, where actually you are using MRD at some point in the trial to drive or to guide maintenance. Maybe you can give us your thoughts about the interaction between maintenance and MRD, and how can we use this in a dynamic fashion?
Yes, so the Yemen group is running the Perseus study, then that has two arms of maintenance. One arm that is with daratumumab and lenalidomide, the other one is with lenalidomide alone. And in patients that has at least 2 years of MRD negativity in the DARA arm, DARA can be stopped and patient can continue only with maintenance. With lenalidomide alone. So basically the strategy here is to de-intensify the treatment in the maintenance arm for patients that have continuous MRD negativity. And this is one of the options that can be considered in the future if we want to look at our data to try to understand if in some patients we can de-escalate the treatment, or even better, have a treatment-free interval, as it was done, for instance, in the master study, where the treatment was stopped in patients that were MRD negative. To me, this is a very fascinating approach, because we are treating all the patients now currently in the same way with the same duration. And from a patient perspective, of course, the possibility to have a treatment-free interval and avoiding the treatment if it is not necessary, because it avoids the toxicity, it improves probably the quality of life, is very interesting. So the possibility to guide the treatment according to MRD is something, of course, several groups are exploring. The IFM group also is exploring in its future trials. So to me, this is the sign that all the groups are currently trying to explore this new approach in their trials.
But Graham, in this analysis and in the Myeloma 11 trial, you didn't use MRD to adjust or adapt treatment.
No, we didn't. We continued Revlimid maintenance regardless. I think one of the interesting things about the impact of maintenance, and I think the Perseus trial has got a very interesting question. I think one of the things we may have to think about is that interaction, though, between MRD negativity and high risk and ultra high risk cytogenetics. Francesca mentioned the master study, but what we saw with that is that people with more than one cytogenetic abnormality who were stopped who were MRD negative did extraordinarily badly. And in our study, looking at high risk cytogenetics in the MRD negative patients, the standard risk patients had a 63-month PFS, but the high risk and ultra high risk group, 33 months. So MRD negativity is not the same in standard risk versus higher risk cytogenetics. And maybe that's something we also have to think about. And Francesca's got some lovely data looking at the impact of carfilzomib on those higher risk patients. And I think that's going to be something that's going to be fascinating to come out of the Forte randomization.
But this is a little bit in contradiction, I think, with the paper published in Blood by Dr. San Miguel and colleagues last year, I think, showing that MRD negativity in the high-risk patients may overcome actually the bad prognosis, and then these patients will rather join or come closer to the standard risk. Is this something where it's a controversy, or there is an explanation?
I think it depends. I think we've got to get smarter about high risk patients, because I think having one cytogenetic abnormality isn't the same as having two or more high risk cytogenetic abnormalities.
So the concept of double hit, triple hit.
Yeah, and we know that people who often have one abnormality, absolutely the differences aren't great. And with better therapies, we're making that gap between standard risk and one abnormality closer. But my take home from the master study and others is that it's that double hit ultra high risk group that we're not impacting on.
One question from this is like a methodology technique. Can you, this is Dr. Alan Krita asking this, can you comment on the prognosis of MRD negativity in patients with CR versus non-CR? Is this something you looked at?
We did look at it and we didn't find any difference. If you were MRD negative, it didn't matter whether you were VGPR, near CR or stringent CR. MRD negativity trumped the conventional assessment. What we did also see, just talking about thresholds, is that even in the MRD positive group, the ones that got lenalidomide, their depth of MRD positivity fell, which was quite interesting too. So even within the 10 to the minus 3, 10 to the minus 4, you saw lower levels of disease in the MRD positive arm of the study if you got maintenance.
Okay, so we have a question here, and I think you mentioned this, Graham and Francesca, also this issue of doublet maintenance. So if we have to design today this Myeloma 11 trial again, would you use the current data as a basis to consider doublet maintenance or even tandem auto in those MRD positive patients? And how would you do this?
Okay, well, I firstly we again congratulate Francesca. I think her maintenance question is a very good one, and we've never had a IMiD versus IMiD proteasome inhibitor randomization at maintenance. So that is a very, very impressive design. I know Francesca's doing it for the Revlimid until progression, and I guess one of the other issues we are talking about is stopping treatment in MRD negativity. But I just highlight the Stamina study and some data from Mayo, who did a landmark analysis at 3 years, and the people who stopped maintenance even at 3 years did poorly compared with the people who continued. So I do get the treatment-free interval, but currently all the evidence does suggest that certainly Stamina and Mayo data suggest that continuing maintenance is good. Now, they didn't look at MRD negative versus positive or cytogenetics so much, but it's still an important point. There's been no study that shows stopping Revlimid is equivalent to continuing it.
Francesca, do you share the same opinion?
Yes, I mean, the data that we have so far are in favor of continuous maintenance until progression, but as Graham mentioned, there is no clear analysis on those patients who are MRD negative and stop versus those patients who were MRD negative and continued. And also the randomized trials will answer this question, and probably trials with an overall survival endpoint, because then you have to also consider what you will do at the time of relapse. So to me, these are the current, the standard is to go on until progression with all patients. And this is the only thing that we can do based on the label and based on what we have from the data, but we need to try to understand if really is needed in all patients, particularly the MRD negative. The other point to consider to me is that we are speaking about maintenance, continuous treatment for years, and you have also to keep in mind the potential toxicities of the agents in terms of short-term toxicity, burden of treatment, and long-term toxicity. And you mentioned the Italian study, the Forte study, where we explore a doublet in the maintenance phase, but the doublet was administered, carfilzomib specifically, only for 2 years because it's an intravenous treatment, and I can tell you that the compliance from a patient that have to accept a continuous treatment upfront for years is not that easy, so this has to be considered. And we all know what are the long-term potential effects in terms of second primary malignancies. That is the potential toxicity of lenalidomide that needs to be considered. So to me, despite these are the data and this is the label, we need to try to explore if we can do something different.
But always, oh sorry, I agree with you, Francesca. It's just dissecting out the thing. I think there are a number of really good maintenance studies that ask some really good questions, and one of the neatest ones is actually Endurance, which was the KRD versus VRD study in patients without high-risk genetics. And they're actually randomizing between R for 24 months versus R to progression. But against that, the 24-month maintenance studies like Cassiopeia with the DARA and ixazomib tourmaline 3, the ones that stop at 24 months, haven't shown so far a massive impact of having a shortened maintenance. So whilst I accept every sensible thing that Francesca said, there still is a question mark about shortened duration of therapy. We haven't answered those questions yet.
But guys, you're confusing me a little bit. Therefore, I'd like to share with you the question for Professor Beksak. Hello, Mural. Do you consider MRD adapted treatment possible? Because now I'm confused with your both answers.
I'm happy to go first. Meryl, I think we are moving towards MRD risk adapted therapy. I would say particularly in standard risk patients. And I accept everything that Francesca said. And if we could get to MRD negativity at 10 to the -6 after 2 years of maintenance with Revlimid in standard risk patients, I would be very keen to look at a study of stop versus continuing. I think we have to be a bit more careful with patients with ultra high risk and high risk genetics.
Yeah, Francesca? I totally agree with Graham. And regarding the last comment on high risk and ultra high risk, I super agree with Graham again, because these are the patients that we really need to be careful. So something that I particularly liked in the paper is that you put together the risk, the maintenance, and the MRD evaluation, and you have these 3 key factors that needs to be evaluated. Regarding the ultra high risk, I totally agree with you. It's very hard to think that you can sometimes stop treatment. The question is probably if you need to do something more if they are still MRD positive. But again, we do not have data now that support that approach. We have trials that will evaluate this in the future, like for instance also the IFM study.
And there's some interesting interactions, isn't there, Francesca? Because you've got some really nice data on 17p and other high-risk site genetics, but your AMP chromosome 1 data shows very little difference between the KR and the R, and that was possibly a shock, I guess.
Yeah, but I think that the key point is if you look at 3 copies or 4 copies, the impact is different. And 4 copies, basically what we saw is that you can do whatever you want, but you are not improving the outcome of these patients. And this is a negative message, unfortunately, but a very important message.
I would agree.
So we have a question for you here, Graham, from the audience. Today, based on this huge difference between the curves, the survival curves we see, would you be willing to start a new treatment for a patient who becomes MRD positive, or modify your treatment?
I don't know that we have enough evidence to say that yet. And against that argument is you do see some MRD positive patients at +9 months who have very good progression-free survival. So we have to do the studies. And as you rightly point out, the deeper the assessments, the more information we will get. So I don't think we have enough data to do to change therapy on patients who are persistently positive. I think the group we do have to watch out for are the ones that go from negative to positive, because they are probably, in all intents and purposes, relapsing, and those will probably go from treating at clinical progression to biochemical progression to treating on conversion from MRD negativity to MRD positive in the future.
So, Francesca, in your experience today, if you start doing MRD assessment to everybody, and assuming you have the greatest threshold by NGS, then -6, who would be your most interesting group? Is it going the MRD negative patient or the MRD positive patient? Where would you think the impact, or you can be more impactful, I would say?
You mean in the maintenance setting, right? Or
yeah, let's take the maintenance setting.
Well, I think you need to look at the risk of the patient. So for the standard risk, the MRD negative, because you see that if they are negative, they have an outstanding outcome, particularly if they are persistently negative. I really like what Graham said, and I would like to echo this, is the kinetics of the MRD that is important. They are persistently negative, so you potentially can consider, if not cure, at least patients where, as I mentioned before, you can de-escalate. The other are the persistent, the ones that are negative turn positive, particularly if they are high risk. You can lose the patient at high risk for bad relapses because the disease basically is too aggressive. Maybe if you can capture the very early relapse with the MRD in these very high risk patients, you can do something and you can improve their prognosis. So to me, there are these two groups with different approaches.
Graham, we have one question here about that MRD evaluation requires bone marrow aspirate. Any update about easier and softer techniques? And I think people are thinking about mass spectrometry. Any thoughts on this? Are we ready for prime time or not yet?
I'm really glad you asked that, Mohamad, because we had an abstract on our mass spectrometry data, which we looked at MRD negativity at ASH. What's really interesting is you can get really good assessments of MRD using mass spectrometry. And I have to say, I was a slight skeptic about mass spec before, but our data from Birmingham shows that mass spec can really, really delineate good and good risk patients. And actually, what's interesting about the mass spec data is it doesn't completely parallel with the MRD negative data that you get from flow. So that it might also be telling us something slightly differently. And as I'm sure we all would agree, we've not talked about imaging, but we can't have an assessment of MRD negativity without being talking about PET scans becoming negative. The Casio PET study looking at PET negativity showed that that's very important. And again, doesn't always give us the same information as MRD by flow or NGS. But I think mass spec has got something really important to tell us. And then we've got circulating free DNA, circulating plasma cells that we're probably not measuring as well as we could. Because when we get down to it, one of the issues about measuring MRD in the bone marrow is patients don't like to have their marrows done. And it gets harder and harder to persuade them to have serial marrows. And whatever technique you have is useless if people won't provide the samples, and that's something that's never discussed, but you get a drop off in the number of people who want to give samples as you go through a study.
Just one comment about mass spec. I appreciate your enthusiasm about it, Graham, but I thought—
I'm a convert, Mohamad, I'm a convert.
Okay, but I thought that the threshold is relatively around 10⁻⁴, which is not yet ideal, I think, given the availability of NGS with 10⁻⁶.
No, I think we've got a lot to learn about mass spec. It's in its absolute infancy, and I completely agree it's not at the same depth. But we're already learning that, as I said, it doesn't always parallel what you're seeing from MRD assessments within the marrow. So maybe it's giving us different information, and also it's going to be useful perhaps for people who don't want to have bone marrows.
So that brings me, Francesca, to the question we have from the audience about the value of imaging and, let's say, PET scan in combination with MRD evaluation. Do you see this as being two synergistic techniques which, provide additional information to each other, or they can replace each other, or one of them would be useless? For instance, one comment we had that if you are able to have a sustained MRD 10⁻⁶ by NGS, actually probably you won't need to have a frequent or regular PET scan monitoring. What are your thoughts about this?
Well, so far the data that we have, for instance, our data that Elena Zamani presented, the Italian data, but also, to the best of my knowledge, the French data presented so far show that there is an an additive value of imaging, because patients that are negative for both techniques have a better outcome if compared with those patients who have one of the two techniques that are that is still positive. So far there is an additive value, and there is a let's say a not so good concordance in the imaging MRD negativity results and the bone marrow MRD negativity results when you look at the imaging data outside of the bone marrow, particularly for the extramedullary disease. So to me, so far the two data are complementary. The key question is, do you need to do the PET-CT in all patients or not, and which patients should get it, and in which time point particularly? And we do not have yet these answers.
So definitely we need a new journal club about this. My last question is to you, Graham. Again, great paper, JCO, superb analysis, but the question is, what's next? Where are you taking this story?
Well, we've got two ways. We've got the Martin Kaiser Optimum study, and we're really trying to look at the ultra high risk genetic patients separately, and they're getting actually some triplet consolidation for long periods of time. And you know Martin's data, it looks really interesting that he might be impacted.
Is this guided by MRD?
No, but MRD is being measured and we haven't got the results. Okay. But the radar study that Qui is SEI for is looking at MRD negativity and positivity in standard risk and high risk cytogenetics. So we've got a risk adapted maintenance study.
Excellent. Well, that was really inspiring and superb journal club about MRD. I think the good news also, we didn't solve all the problems, that clearly we have great techniques to evaluate MRD, flow cytometry, which can allow you 10-5, NGS 10-6. We are quite confident about its prognostic value. The next step is how are we going to refine its use for guiding treatment or adjusting maybe treatment, but also being useful to patient if it allows, for instance, to stop treatment, and that would have some pharmacoeconomical positive consequences, I would say. But on the other hand, maybe improving the prognostic of the patient, if especially those who are MRD positive. So we still have a lot to do, but I think it's always good to discuss a problem, although you cannot always settle it. So thank you very much, Graham. Thank you very much, Francesca, for dedicating some time at the end of the day. I know probably it has been a busy day. I'm very grateful. Thank you all for following the ICH Journal Club and activities in general. It's always a pleasure to interact with all of you, and I do apologize if we were not able to take all the questions, but this virtual digital world is quite amazing, because when you are in an in-person meeting, you may end up in a session having 2 or 3 questions. In a webinar like this one, you have dozens of questions. So this is really, I think, a great news. And I think the digital education is here to stay. And we at the ICH are very proud of this, because we have pioneered this in October 2018. So that was a long time before the COVID. So thank you for being loyal to the ICH. Our next activity, I believe, is in a couple of days on Thursday, 19th of May. And this is going to be a beautiful webinar, sort of an update about the use of CAR T cells in non-Hodgkin lymphoma. But this is by Professor Rock Huo from the University Hospital of Rennes. But that's another story. I hope you will register and enjoy it. So thank you, Graham. Thank you, Francesca. And wherever you are, please stay safe and keep well. Take care.
Thank you.